There we go. Meeting of all the jurisdictional networks for the 911 systems for the largest cities in the US and elsewhere, and our friends from other organizations that help us out. I have to send this meeting draft. I'm going to try to compose something to someone and send them a invitation to this thing. In the meantime, while doing that, but on the agenda so far, I wanted to start off with Jim to sort of reiterate the report about the drug shortages. We had a little, we did a review yesterday across the state of Florida to see if we were missing any of those important things like amoxicillin or Tylenol and so on that were missing in other states. And,
Collier.
Hello? Yes? What's that? Okay. Any event, what I was going to say was yeah, I'm sort of like got my brain twisted from that last one. So, but any event, we have an even broader problem across for EMS for all of us, anyways. And so, Jim, you want to give us a highlight of what the latest is? You've been really good about keeping track of this.
Happy to, and there's some Christmas music going off in the background here. I apologize. I'm at fire headquarters, so.
Oh, okay, got it. That's delightful as long as it's not as long as we can hear you. So, so far
Yes.
You're here. We're hearing you pretty well. So good.
Good. All right. Our drug report. We've kept these. Everyone knows since 2011. 2011. So this is 11 years of drug shortages. Each week or month, depending on how quickly they're changing, we get a report from Boundtree that talks about back orders. And from that, I both chronicle them so that, for example, your state EMS organizations that want to know what drugs are in shortage so they know what not to expect in inventories as they go do inspections. They are kept. And then I kind of number them so that we know how many preparations are in shortage. This month, we started off with 75 preparations that are short. Over the last 11 years, we've been down as low as about 40 and as high as 120. So we're mid-range. We are a little shorter than we were in the middle of the summer when we were at 100. Nonetheless, this is still many of our favorite medicines. Particularly important now, etomidate is short, atropine is short. Any of the dextrose 50% are short and 25% is not available. Dopamine, fentanyl is in great shortage. Ketamine is in great shortage. Lidocaine is in great shortage. This past week, we had a meeting with the federal drug, the FDA task force chair. We do those monthly. And a number of the other Eagles are on that call. Our report this month was from Pfizer, tried to give an explanation about why there are shortages in the industry. Pfizer now owns Hospira, which makes a number of our injectables, and they are running into all forms of problems trying to manufacture drugs. Of significance for all of you is that this week, Sandy Schneider started a reach out to Mark Cuban's Cost Plus drug. I don't know whether to call him a manufacturer or distributor, but Mark Cuban has been working on a process of getting medicines that are in short to people who need them. The Hospital Association the AHA has reached out to Mark Cuban to see if he would look at our very basic substances that we need to run hospitals, like lidocaine, like ketamine, like fentanyl, et cetera. And then we have asked if EMS could be added to that list in contact with Mark Cuban. So Paul, our problems persist. They don't show any signs that they will resolve in the near future. It causes a lot of logistics and other issues across the industry, as well as patient care issues, as well as very unhappy paramedic issues. And I don't have anything that would tell me that this is going to go away.
So let me ask you this. Can you name like the top 5? Well, just want your opinion, okay, which is fine. And because I trust your opinion, we're like the top 5 things that we really need in EMS that we can't get. And do we
Yeah.
have alternatives? And does anybody have standing alternatives that we can pass around to each other?
We have given a list before to the FDA, believe it or not, maybe 2 administrations ago. The FDA asked for our most important and life-saving medicines. We gave them a list that would have included things that are used both frequently and don't have good substitutes in our world. And so we gave them the list of medicines like epinephrine, like dextrose, like mag sulfate, like our pain control medicines, which have run through, whether it's morphine, hydromorphone, or fentanyl. We need one of them available for pain control. We need midazolam, which has so many uses to it. And I think bicarb was another one of the chronic shortage medicines. In the intermediate, we had lost a lot of our IV fluids, and we let them know that we can't run the industry without IV fluids. So those were both for importance, the lack of alternatives, and the frequency of use.
Okay, so a couple of them, are, I think, I would rank higher than others, like the epinephrine and so on. Maybe not so much bicarb. We used to, I think the one real emergent situation was going to be either maybe hyperkalemia. There's other alternatives there. And maybe, what do you call it? The antidepressants, the certain antidepressants that widen things out. But so I just want to know is how are other people approaching this? And do you have a good, let's say, a plan to share with everybody beyond the fact that you'll use it beyond expiration points, right? And by the way, if so, what's the toleration on that? How far do you go beyond the expiration point and so on? So anybody have any suggestions or comments about that or what they've done? Or protocols, okay? Hearing none, well, then maybe we have to do it. Ken, do you want to talk a little bit about this, or do you want to divert off on the issue of the childcare issues? Or do you want to just make some general comments about when you've approached problems like this?
Well, first, in Florida, you cannot use expired medications. That's a state pharmacy law, so that's not an option to us. So alternatives is the only thing that we can do. What we've done is what several of others have done is in our protocols is have anticipatory things in the protocol where we'll have use this one if available, use this one if that's not available, use this one if not. So we put the alternatives in the protocol, so you don't have to keep rewriting whips on paramedics and making you familiar with names in advance.
Okay.
Ongoing problem.
One suggestion is you just do what you've been doing is getting people reperfused with the ACD, ITD, and then elevating their head and just getting them back to normal flow, so you don't need to use epinephrine. But the area where I really would worry about is anaphylactic reactions and so on. And what's your plan for that if you didn't have any epinephrine? Is there one?
I don't have a good answer for that.
Okay, got it. All right.
You need Epi for that. I don't know of a good alternative there. But
Okay.
with the D50, we all switched from D50 to D10. So there's been some ready answers, and sometimes it's driven us to even better answers, right? Because
tell me now, you did a survey yesterday briefly, sort of a very informal one, but just a survey of Florida about what's happening there with the very well-known or well-publicized shortages of drugs for children, particularly the ones that are getting into RSV and flu land, right? And or the lack of amoxicillin or the lack of Tylenol, et cetera. And what did you find so far? And do you have a reason why it's better in Florida?
We were on a call with when I say we, I mean the State Surgeon General. I were on a call with the FDA last Friday, and it was a national call, and we had the people from the Department of Health in New York State talking about how there are shortages of amoxicillin, albuterol, pediatric Tylenol, pediatric ibuprofen, and generic Tamiflu, and it's because they're having the triple demic of RSV, flu, and COVID going on. So and they mentioned how folks were going to pharmacies and just could not find these medications. So we did it's sort of an informal survey, thanks to this sort of network we have, that we have Global Eagles. We've set up something similar in Florida, a smaller network, but still gives us a good quick sampling And we are not seeing those problems in Florida. I looked at our own flu stats. Our rates of influenza have been dropping lately. Our RSV has been dropping as well. COVID just has gone up since Thanksgiving. But so I think it's probably just a matter of timing. You know, these waves of infections don't hit every part of the country the same rate. So we're just not in a big wave that Northeast is.
Okay. So anybody have any other comments or suggestions or protocols that you use for drug shortages that you can contribute to the group? If not, let us know offline. I just wanted to tell you, the same thing. And I think that's important to know, like Joe Holly was saying, it's illegal to use drugs past expiration in Tennessee as well. And you have no authority to do so. So a lot of us are facing those kinds of issues. So let me run. First of all, does anybody have to get off at a certain time? Because I want to get around to everybody today, and we have a couple presentations. I just want to make sure I don't miss anybody and so on. And Mike Sayer, you're on from Seattle. Haven't heard from you for a while, so it'd be great to see what you had to say and see if there's anything new to report, or if there was something specific you were looking for here today with the group.
No, Paul, I'm just lurking and learning. That's what my goal is for today.
Hey, so I know you have other things that are going on usually on Tuesday morning, so it's been really prohibitive for you, but we're now going to move. I want to send out a notice to the afternoon and probably do it at 12:30 your time, to see if we pick up more people that way. Or at least it's an experiment. We'll try it for the first of the year. I just want to make sure everybody puts that in their calendars now. So just so you're aware of it. So is that a better
Great.
time, by the way?
For me personally, it's a great time.
Oh, fantastic. Okay, well, that's what I'm finding out, which is really good. And most of the people on the phone will adjust for that, which is really good. All right, well, good. Thanks a lot. So nothing new specifically there. And you don't have people in nursing homes dying from some virus that came from Asia.
Yeah. No, it's just the normal stuff, the normal flu.
It was funny that that the Pacific Northwest ended up being the canary in the coal mine for us. What was interesting, you guys had it there for several weeks, or in Seattle, and then we didn't see it anywhere else. And then I remember we went to Florida, and the second case, the second state to have it was down in Florida in Hillsborough County, Tampa, where we were having the EMS today, I think it was at the time. And that's where the second, the first out-of-state case came, outside of Washington State. So there was a period of time that you enjoyed some, loneliness there on that. I'm glad you did. So yeah. It was amazing what took off after that. So it's really great. And the great job you did. You helped us all out. And then, people like Ken is the greatest R&D guy, rip off and duplicate, and then he just makes it even better. And so just all was very, very helpful. This conversation with you helped and protect a lot of people in Florida, especially because there's so many nursing homes down here and all that kind of thing. So thank you so much. So it's great to see you again, and we'll hopefully get you out more often. Okay. But you're not any new protocols going on there, or anything you're studying right now?
We're let's see here. No active research right now. We're kind of between studies, hoping to get one started in 2023.
Okay.
But the waiting for the IRB and how that goes. So we'll see.
Can you tell us what you're going to be looking at?
This is a Tom Ray adventure
Okay.
related to using comparing early i-gel versus bag mask ventilation.
Got it. Okay. Got it.
And then so we'll see. I don't know. The IRB is being challenging, but hopefully we'll get through them.
And is that going to be used with mechanical ventilation and or standard chest compressions?
So this will be at the first responder EMT level.
Okay.
And so they won't be using any mechanical ventilation.
Got it. Okay, good. The reason why I brought that up is last year, RJ Franscone presented to us that he was seeing, these cases of with the mechanical, there was a lot of leakage with the i-gel, which is a lot of people feel is the drug of choice, so to speak, there. And so just a admonition and or consider that kind of thing.
Appreciate that. Yeah.
Great. So let's go on and go to a few people that have to get off pretty soon. But first, I want to see Chris Colwell. You're out in California, right? And you guys have been pretty aggressive in the past about, masking up and so on. Is that going to be feasible now that it's become such a political thing and so on? And are you advising it, or what do you think? What's your opinion about that? Since, you're right in the middle of it. You're probably how's your hospital doing, by the way? You're probably overwhelmed, correct?
Good morning, everybody. Yeah, I think we're in probably the same boat everybody else is. We woke up this morning to boarding 45 patients in the emergency department, and when you only have 72 beds, that's a pretty substantial percentage of beds that's boarding. So we do represent the busiest inpatient ward in the hospital now as the emergency department.
And this is all adults, correct, at your place, correct?
No, we've got kids too. Although we're not, we're seeing a lot of kids, but we're not having to admit very many kids.
Okay.
And so they're not providing the boarding issues that we have. We actually have some adults admitted with RSV, which is a little bit unusual. We're back up to 25 COVID patients. We've got 12 influenza patients and now 5 RSV patients, 4 of which are adults in the hospital. Those are admitted patients. And so we're just, we're experiencing the same thing everybody else is. It's a bad respiratory season. It's an early respiratory season, and it's we still haven't completely recovered from the pandemic related staffing issues and all of those. So we're really in rough shape, not only just as a hospital, but as a city, just trying to find a place that has a bed to see acute patients in. In terms of masking, we've seen our current influenza testing positivity rate is at 27%, which is kind of unheard of for us. Normal rates are down in the 2 or 3% range. Statewide, it's up at 20%, but San Francisco is 27%. So we're really seeing a lot of the influenza as well. So we have asked for not only masking in all hospital and patient care situations, but also we have not mandated, but recommended masking at the firehouses and all other areas, even not acute patient areas as well, just because obviously the impact on the workforce. But we have not mandated anything yet. If it were up to me, I might push in that direction, but I realize that's not a popular move at all. It seems like with the viruses that are being thrown around now, it just doesn't make a lot of sense that we're not going to try to protect our workforce at the same time.
Yeah. So are you requiring it in the hospital?
Yeah, so we require anywhere in the hospital a mask, and then we're back to requiring N95s for direct patient care with respiratory complaints.
Okay.
But we're requiring a mask anywhere in the hospital.
But you're not doing it, say, with the fire department at this point in time, correct?
Right now, it's with the fire department. It's a recommendation.
Okay.
Yeah.
But yeah, sometimes I always wonder if we should, all get together, band together and make that recommendation. Let me do this. How about Steve? Let me run down I-5 to Steve Sanko. Anything to add on to what you just heard from Chris? And by the way, Chris, great talking to you, and I hope you follow up with that thing with Peter. Okay, so just remember, right? Yeah.
No, maybe we're seeing high positivity rates for influenza testing as well. The one caveat is a lot of hospitals are requiring that you reach a certain that you require admission in order to test for influenza.
Yeah.
Otherwise, they have outpatient COVID tests, so it may be messing with the mathematics a little bit. But mask wearing is still voluntary. They're currently voluntary in LA County and LA City. But yeah, we're seeing a lot of that. We're still dealing with drug shortage issues as well, as Jim was alluding to.
Yeah. And the same ones you're hearing there, anything that's different that you're experiencing?
No, Versed is our particular pain point these days.
Yeah. Okay, got it. So that's thanks a lot for that report, all that. Let me jump over to other parts of the country. David, what are you seeing? You said you're the public health director in Houston as well. What about over there?
Yeah, so here in Houston, we're in another upswing of COVID. So our wastewater is going up like 30% to 40% per week. And that generally predicts what's going to happen with positivity rate and hospitalizations by 2 and 4 weeks. And in fact, it's following suit. So our hospitalizations are going up. Now, most of those are people, with COVID as opposed to because of COVID, but about 20% of the admissions are because of COVID. So we are starting to see, that again. Our flu seems to have peaked. We've started seeing a downturn in that, and also we're checking in the wastewater. We just started reporting out some wastewater on flu, and that's down in our RSV may have dipped as well. But so with here in Houston, just like I think everywhere else, this is a really early flu season. We routinely don't see flu until after January. We have seen it in November before, but routinely in January. And we've also had many years where we've seen, double waves of influenza. So I'm fully anticipating we'll have a second wave of influenza probably January, February, when we usually see it. Our hospitals are, they're busy, but nobody is locally. I mean, they're whining and complaining, but nobody's in a panic yet.
Yeah. Is that whining like with a glass of wine or? Oh, I'm trying, wrong city. Okay, got it. Hey,
Yeah.
well,
Hey, so
listen,
let me just add one thing. I did have an opportunity today to I was on a conference with Ashish Shah at the White House, and I
Yeah.
complained to him that the emergency department overcrowding is largely a man-made problem. I mean, everybody sort of blames whatever they want to blame, but the reality is the reason the emergency department is overcrowded at 8 o'clock at night is because the hospital admitted too many elective admissions at 11 o'clock in the morning. And they do that knowing what impact it will have on the emergency department at night. So everybody talks about the emergency department being the problem. That's not the problem. The problem is that they are knowingly admitting too many electives earlier in the day. But the reason they do that is because those elective admissions are going to make money, whereas the return on a
Yeah.
viral pneumonia admission is break even or a money loser. That is another man-made problem, and Medicaid and Medicare could probably take a look at that. And if they made it so that the viral pneumonia patient was a money maker, I think our nationwide emergency department overcrowding problem would be greatly alleviated.
interesting. So it's
We'll
very
see.
twisted. Did anybody disagree with that, by the way, or do you feel like we see the same thing where we are? That's what I was expecting to that. And Doug Swanson from Charlotte, what's your reaction? Because you work a lot in the hospital as well.
Yeah, we are much like Chris. Our ED is the largest inpatient unit in the hospital. The thing we run into often is that we may have 40 boarders with 50 open beds, but those beds are all being reserved for operative cases the next day. We've stood up our mobile hospital, Med One, as a surge unit outside our ED to help see some patients, because we just don't have ED beds to see patients in.
Okay. Well, let me ask you this. Let me just think, since I guess we all kind of know this problem, and just if we are some solutions that are a way to identify it and bring that out. I'm glad people like David are out there bringing some national attention to it. But let me ask you this while I got you on: anything new in Charlotte or with the EMS service, or anything else anything you're trying new, or anything new happening out there with you?
Still working on our response reconfiguration and changing some of our timeframes, and we're actually going to the Board of County Commissioners policy meeting this afternoon to discuss it with them.
Okay, and give us the 20-second bullet thing that you're changing, your configuration.
So we want to keep our highest priority patients the same, with the same time frame, which for us is 10 minutes and 59 seconds.
Okay.
But we're adjusting others from 12 minutes and 59 seconds out to 15, from 20 out to 30, and then extending another subset to 60-minute response time.
Okay, got it. Okay, thank you then. And David, let me pop back to you. Anything new happening within the EMS system since we got you on there? You're muted in case you don't know that.
Yep, sorry, thanks. So the only thing that big that's happening here within EMS is we are going back to the squad program.
Okay, good.
So, yeah.
You're happy with that, right?
Yeah. So, I've had the experience. I've had two fire chiefs in a row who came from outside Houston who both said, I don't understand why you have these squads. We didn't have them where I came from. And
Right.
first one dismantled half of it, and the second one dismantled the other half. But both of them, before they left, came back to me and said, I get it now. You were absolutely right. I shouldn't have done that. But this second one has actually been fire chief long enough that he's now starting to reverse it. So
Yeah.
fire chiefs can learn. They
Yeah.
can. Anyone who doubts that, they can learn.
Okay, good. So in any event, this is like amazing. David, what is this like? You're over a quarter century, right? You're into that club. That's fantastic. So it's
Yeah, I
good.
think I'm 26 or 27 years.
Yeah, it is. Yeah. So yeah, you're getting on to 27 in 6 months. So whatever it is. So great. So it's great. Thank you so much for your participation here. Later, I'm going to have maybe I was looking for John Jew to talk about what's the latest in these things and what they're predicting, what's going to come along, at least around the country. And hopefully Eileen Marty will get on as well. And we'll talk a little bit more about the infectious disease things, but let's get off of that for now and go to some visits around the globe. Fiona, are you still here? I know you have to get off pretty soon. Fiona Moore from the UK. Hello, Fiona. Well, so anything new from your end? If it's new, if it's new, it's not good, right? If it's not new, it's not good, right?
So it's more of the continuation of the whinging from last week.
Yes.
So we have now had 15 deaths in children and teenagers from invasive strep. And this has caused an absolute tsunami into our 111 call centres. The volume of calls from the worried well's gone up by about 60%. Primary care is inundated. Emergency departments, particularly paediatric emergency departments, are inundated. We had a wait of 10 hours to see a doctor in the Royal Alex, which is the children's hospital down in Brighton.
Yeah.
So that's invasive strep.
Let me ask you about that. I want to ask you more about that though. So last time we talked, they were all more kids 5 years and younger. I think you had one at 7 years or whatever it may be. But so two questions I'm going to ask you is, one is, you said adolescents are, so we're seeing upper ages getting into it as well. And number two is that just the tip of the iceberg in terms of the deaths? Are there a lot more cases who are like in ITU, for example?
No, ITU beds seem to be okay. So we've got a lot of kids presenting with scarlet fever, because if they've got scarlet fever clinically, they shouldn't return to school until they've had a course of antibiotics for 3 weeks. Yes. So that's got significant implications for the workforce. So we've had cases of children of 9, 11, 12. I'm not aware of any adults.
So we all have to get smart again about how scarlet fever presents, right?
Yep.
All right. Okay.
And the only really constant feature appears to be the child that is just not improving and continually deteriorating. And of course, that's very much in the eyes of the parent. So we are seeing a lot of not very unwell children. So that's IGAS. Then flu A and flu B are both increasing, and RSV is going down. Just coming back to strep A, actually, it would appear that we're getting this earlier this year. There's no indication that the numbers will be higher overall. It's just happening earlier.
Okay.
Okay. And the other thing we have is a shortage of antibiotics. So it's virtually impossible to get Pen V liquid for children. People are traveling 100 miles to find a chemist that's got it. We've probably got enough of the drugs. They're just in the wrong places. And then finally, and probably
what's the alternative you're considering if you can't get it?
Amoxicillin or azithromycin for the penicillin allergic.
Got it. Okay, thank you.
And a change in the law so that a pharmacist can essentially give you a different, not just a different formulation, but a different drug if they don't have it. At the moment, if you take a prescription in, the pharmacist can only give you what's on the prescription. So people are then going back to the emergency department to say, I can't find a pharmacy that will give me Pen V.
Oh, God. Okay.
And then the last bit of really good news is that we have industrial action coming our way. We've got the railways out on strike today. We've got Border Force out over Christmas. We've got the post office out, so you won't get your Christmas card this year, Paul. And the nurses go out on Thursday, and ambulance staff go out next Wednesday, the 21st, and the following Wednesday, the 28th. Now, not all unions have got the mandate, but it's going to be probably a major problem for us, for London Ambulance Service and for the Northwest Ambulance Service, where we have the militant unions.
Got it. Okay, and then again, the impact on EMS is because of what? Just so I got a better, clearer understanding what the direct relationship is.
That our staff won't come to work.
Got it. Okay. Yeah, okay.
Quite simple, Paul. They just won't come in, and or they'll be on the picket line. And
I
although
remember-
we are negotiating derogations, but
Right.
what happened last time is that we negotiated that they would respond to emergency calls, but they interpreted that as we'll decide what the emergency is.
Yeah.
Or what is
I
an
remember-
emergency call?
That was one of my favorite talks years ago where you came on and you had all the strikes and so on. And, and it was, and you questioned it for us is like, what if 80% of your people didn't show up to work that day? Or what if your dispatch center blew up, right? What's your backup plan? So yeah, so we'll be following this closely and hope you'll give us some good reports on that. I'm so sorry what you're going through. Geez, just, whatever. It's like, it is the show that never ends over there. I'll say that. Right? So let's move over to, let's probably go across the sea there over to Dublin. And Mick, what do you got to report for us? Anything? Or you wrote something in the chat. There's a disaster. Maybe. Okay, but go ahead. There's some reason why you're not coming through, like audio is missing and all that. Are you at home today? No, it's muted. No, can't hear anything. Sorry. Not muted on your side. Okay, got it. I don't know what to tell you. It seemed like a transmission session issue, I think. Because occasionally we see a little voice coming through for a second. Yeah. I'll tell you what, why don't you just sign off, come back on again and see if that helps, okay? Let's just do that. We'll come back. Hey, Mick, before you go though, I just wanted to make sure, did you see what I was wearing today? Right? I thought you'd like that. Those guys are great over there, so thank you so much. All right, let's do this. Let's move over to a couple of people that I do want to hear from. Abdo, you're down in France. What's going on there on your end? I don't know if you've been hearing the conversations about hospitals being overwhelmed and so on. And so what about in France? Are you seeing similar things, or what's the patterns, so on?
Yeah, thank you, Paul. I guess that we have the same issue like all the colleagues in US, in London. We're having lots of overcrowding, much more than we used to have before. We're having lots of people boarding in the emergency department in the morning, and over 100% of our capacity. Let's suppose in my department, you have 35 beds in the emergency department. We're having boarding in the morning 53 patients, almost every morning. So we're almost 200% of our capacity. Our major problem is our beds. We're losing 20% of our beds because of shortage of staff. So hospital have closed 20% of our beds. So nearly in all France, we are closing between 10 to 20% of our beds, boarding beds. So
has that been leading to ambulances being ramped up, and not getting in or unable to load, or
no,
what?
We have a system of dispatch, medical dispatch, that we can have all ambulance coming in. The problem is that some of the patients that will go out from our emergency department back home with ambulances, we don't have ambulances for that. So they are boarding in our emergency department. But the ambulance, we are trying to get them all in time and not really having them queuing outside the hospital like we saw in London during the COVID era, because we're dispatching the ambulances in more or less a wise way, let's say, not to have this kind of queues.
Are the ambulances there part of the national health system, or are they private, or are they companies or hospital based? What are they in your area?
There are two different ambulances. The private ambulances that are private, and they operate either because the dispatch center will ask them to operate for emergencies, or they operate with the center that every doctor can call the ambulance to bring patients to the hospital. And we have the department that has lots of ambulances, is really well dispatched all over the territory, national territory in France, and they bring also patients to the hospital. These are the major two ambulances. We don't have others.
The reason I was saying is that in many jurisdictions in the United States, we do have private ambulance services that will say transport people to nursing homes or back to home or wherever they're going. And that was becoming a shortage for us. So the staffing issues are interesting. We'll hear later that there are some very clever things going on that people like Mike Sayer and David Pearce did for years, but going on in other places around the country, such as in Fort Worth and Atlanta, where we're changing the staffing configuration of paramedics and basic life support units. So that's why I was kind of curious. Okay, so
exactly same issues. Yeah.
Got it. Okay, so Amal, do you have anything for us this week or just sitting in?
Paul, I'm enjoying this.
Huh?
I said I'm just sitting in.
All right, good. Then we'll give you something. Okay, there will be a fun thing that's going to come up about defibrillation, defibrillation related to end tidal CO2. Like, when's the timing? Okay, and maybe another surrogate marker for things we talked about in the past about amplitude of VF or median frequency of VF, and it's sort of another indicator of flow and better outcome. So if we get some chance, it's a little long, so I got to make sure I put other people on first, which
Sounds
means
great.
I'm going to first pump over, and I hope you're okay time wise. That's all.
Sure.
Because I think you'll like it. But Ben, you wanted to give us that quick update. If you don't mind, I want to give you a chance to give that quick update on xylazine that you did for us. This was a really cool thing that Crawford introduced to us. And Crawford, can you just quickly tell me that are you still having similar issues or things under control, better control there? Because you were talking about waterboarding with, with Narcan because of the naloxone. Because people weren't waking up as fast as you'd like because there was xylazine mixed in there, right? Are you still having those same issues?
Yeah, I mean, that's been baseline for us for years now. So it's not like it was a spike or anything like that. It's just part of our general ambiance here in Philadelphia.
Yeah. But the rest of us have learned a lot from your experience, though, as a result, that kind of thing. But Ben, so how are you dealing with it over there, if you don't mind, in Milwaukee? What you had some training video that I think you put together. You've been doing great work out there, by the way. So
oh, thanks, Paul. Yeah, I like it described as the general ambiance. It's becoming our ambiance here in Milwaukee as well. It's been about 3 years now that we've had xylazine, not nearly as much as in the Northeast, but we've seen it increasing more and more and more, that it's a large percent of overdoses now. So I had sent this out. I'll share my screen here.
Yeah. And by the way, as he's doing that, I just want to remind everybody that today's CME number is 15345, 15345. And for those of you that were on the earlier call in Florida, 15346. All right, go ahead, Ben, hit it.
Sure. Yeah. So I've been doing these little shows called Smarter. It's public messaging. It's fairly simplified, but just gathering different folks who are active on Twitter around the country to talk about different health issues. And so we actually recorded this one about a month ago. And I've been kind of sending them out. So I don't know if you want me to show it, Paul, or just send the link out. It's 2 minutes long.
It's like, what is it, 2 minutes? Let's just look at it. That's fine. Okay?
Let's see how this will
I want
work.
to give an example of what you do. So it's really cool.
I don't know if you hear the sound.
Not hearing sound, that's a problem. Okay.
That's a problem. Let's see if I turn it up, if that makes a difference. Probably not.
Right. Oh, there you go.
Yeah. You hearing sound?
Better, but not quite good.
Welcome to Smarter. I'm
Ben. Oh, here.
Joining me is Ryan Marino, an emergency and addiction physician and toxicologist out of Cleveland, Ohio. Does that work? Are you still seeing it? Excellent.
Yes.
Okay. At Ryan Marino. We're starting to hear more about overdoses involving this drug xylazine. So what is xylazine?
So xylazine technically is an alpha-2 adrenergic agonist, which is kind of just jargon for the fact that it is a drug that functions a lot like clonidine, which is usually used for blood pressure, but has a strong sedative effect on the central nervous system, lowers heart rate, blood pressure, and even temperature. It is only approved for use in veterinary medicine in this country, but is showing up in a lot of street drugs, particularly opioids on the street like heroin and meth.
Okay, so when somebody overdoses and xylazine may be involved, how does this change the approach to that person?
So it shouldn't necessarily change the way that we're treating them, but it makes it a little more difficult to deal with the overdose. So in terms of someone experiencing an overdose, you still want to do your same thing, give Narcan if you have it, administer rescue breathing if you're trained to do so, and call 911. But with xylazine on board, someone might not respond as well to those interventions, and particularly Narcan, and it might make it a little more difficult for people to treat them clinically in the hospital as well.
Interesting. So certainly additional risk when this is added to other drugs. Now, what about these skin effects that we keep hearing about?
So these aren't entirely understood at this point, but it is something that is pretty widely reported in association with xylazine. And xylazine seems to have some effect where it can cause pretty significant skin rashes, wounds, and actually necrosis and breakdown of tissue.
Wow, well, certainly something new to be aware of and watch out for. Thank you for making us all a bit smarter. Yeah, so it's just these 2-minute clips. They're short, so you can't fit a ton in, but some general information on different topics. So
I know you sent this out to us all by email, but if you don't mind, if you could stick a whatever, it's a link or something like that, we can look at
yeah,
in the what do you call it, in the chat here, that would be fantastic. And the other thing is that in theory, this goes out to thousands and thousands more through EMS World, because this is recorded, and so that it'll be helpful. That's why I wanted to have you do this here today and even present it, so you have a little bit of a clue. Yeah, we couldn't hear it really well, but it still was very useful, and I thought that was a great thing of that. So Ron Ross said that Dr. Marino is a PIT and tox graduate, right?
right,
So,
yeah, and he's in Ohio now, so all sorts of high opiate areas.
yeah, sounds good. All righty, so excellent. That's good. Well, thanks, Ben. And so Ben, in the meantime, what else is going on in your world? Anything new in over in Milwaukee?
Yeah, so we're just chugging ahead with our dashboard project, our image trend consolidation of our 14 fire departments, and then working on our guideline updates and some quality improvement updates, some new benchmarks, but nothing too new over the last week or so.
Okay, good. You got ice and snow there yet, or just cold?
We're working on it. We had some snow this weekend, but it all melted, so now it's just cold and dreary.
Meanwhile, I don't know if Mick is back with you, but he got hit by a real winter bomb, I think, this week. That's a little unusual. It's
Yeah.
happened before in Ireland. Do you want to tell us about that? All right, you back yet, Mick? Yeah, unfortunately, it's still modulating. I don't know what happened there. It's really weird. The transmission is not good. So I don't know if it's a bandwidth issue or whatever there. So, well, I'll tell you what, let's try it. Let's just as an experiment, maybe try turning your video off and see if it can be better. All right, try it again. Not well. I think you said hear that, but it's not doing real well. All right, Liz, if you don't mind, send us some smoke signals later and we'll catch up with you. It sounds like we're just gonna have to catch up with you maybe next week or whatever. So I don't know what's happening. All right, and so we'll see if you get back in, do interrupt me and so on. Yes, go ahead. Who's that? I was wondering if that was him. Yeah, it's not coming through well, mixed. Start over again. All righty, so I'm going to start going around talking to some other folks in the interim. So if you don't mind, I just want to catch up with a few. First of all, Corey, you're pretty quick. Anything new happening in Nashville that we need to know about?
No, absolutely not. There's probably a lot happening. I just don't know about it.
Oh yeah, that's right. They're hiding it from me. Hey, are you using that xylene on your skin? Is it working out pretty good?
Well, it's cleared up my acne.
Okay, good. Well, thank you very much, sir. Good to see you. Scott, anything in St. Louis? I haven't talked to you in so long. Scott?
No, nothing real going on in St. Louis. It's that time of the year where everybody's in between holidays and no major projects are started.
Yeah. Okay, got it. Ron, anything in Pittsburgh? Hello.
Yeah, surprisingly, we're very similar to France. Our problem is that we don't have nurses. So for us to stand up a tent, it couldn't happen because we don't have people to staff it.
Got it. All right. So I hope you fix that problem. And when you do, let us know how you did it. Okay. Well, good. It's good to have you on though again, Ron, and we'll move on. Rob Dunn, anything in Detroit?
Well, a lot of the same stuff that other people are experiencing, but I'd say that the thing that's on my list the last week or so is Candida auris. We've had a number of nursing homes and hospitals with outbreaks leading to some recommendations about, enhanced cleaning of ambulances that are coming from these places, pre-notification. This is a multi-drug resistant Candida species. It's been kind of a problem in the US since 2018. But apparently it's really accelerating. I've looked at some of our state data. I haven't really dove into it, but I wanted to bring it up on this call. Literally, I was late getting on because I was on a call with our state investigators about it. And it doesn't seem to me like we really have a handle on how big this outbreak is. And I don't know what other people are seeing with this.
What's good? Well, what I'm going to do is send me an email this week, and I'll specifically ask John Jew and Eileen to address it. Okay.
That'd be terrific.
Yeah. Okay. And then Rob, anything you can say about it? Rob Holman, since you're our other ID guy.
This has been around for a while and a big concern in the hospitals when they hospitalize patients with catheters. I have nothing more to say about our role in that.
Okay, got it. Anything while you got you on? Anything new in DC that we need to know about it? Everything okay there?
This week, very bad traffic because we have about 12 or 15 square blocks closed for the African Leaders Summit.
Oh, okay.
And we have everything else. There are 10 states and DC that are listed by the CDC as very high in influenza.
Okay.
And, that's that. Our call volume has been horrible the last 6 weeks or so. And our ED walk-in times are double-digit hours. Our times are averaging 75 minutes for us and more than 90 for our private BLS. So yeah, it's just bad everywhere.
Yeah.
We have a 911 call center director whose nomination was pulled. And if any of you have excellent call center directors, please let me know and I'll try and kidnap them. So
okay, that sounds good. All righty, good. Well, that's really helpful. So hey, Rob, in the meantime, I understand there's also an outbreak of Lyons fever out there. Is that right? In Detroit? Is that true?
Yeah, and that happens intermittently, usually leading to fatal outcome.
And it's like you compensate for a while, right? And then it crashes.
That's right.
Okay. Okay, good to know. Well, I hope you're around to keep them from choking with the Heimlich or whatever. So good
I
news.
hope so.
I got to get these other folks on. I still want to go around the horn and check in with everybody. But so let's start, if you don't mind, I guess with Ginny and/or Mike Hubble, okay, who are two fantastic. They're both PhD types that are working out of Wake County and been professors and chairs and things like that for many a year in that arena of EMS education. And they're also doing some really good academic work. And one of the things they were looking at was this issue. And I'm almost saying, like, just if you don't mind, get to the results that you found, because I think we usually take about 5 minutes for each of these things. And if you go over to your results and then you go back and discuss it a little bit with us. But bottom line is I'll tell you, not to bury the headline, have made a correlation with end-tidal CO2 and the ability to defibrillate. So if you don't mind, can you come on up and do that for us, Mike?
Sure. Let's see if I can.
And I know also that Ginny's got to leave like in a few minutes. So
yeah. Okay. And you just want us to jump over to the results on this?
Yeah. Just go to the results because because that's what people are. Everybody knows pretty much they're on this phone.
Yeah, sure.
Okay, that kind. And then we can go back and talk about your methods a little bit, right? But I think most importantly is you could tell us 324 patients and what group were they from, et cetera, and then go through it. But that's what everybody's looking for. We want to know what did you find? We want to see those charts is what everybody wants to see. Okay.
Okay, good. So yeah, so we were evaluating the predictive utility of end-tidal CO2 for defibrillations, and we had about 324 patients there, 869 shocks. A handful of them there were first shocks. The majority were succeedent shocks. And what we noticed was that if we look at if I can get to it here. There we go. Can you see the slide?
Yes, sir.
Okay, all right, great. So what we found there was when we started looking at the first shock that was delivered, the two things that were predictive there was bystander CPR, had an odds ratio there of about 4, so pretty significant effect there for bystander CPR.
Right.
And the end-tidal CO2 was also predictive, 1.03, so about a 3% increase in the odds there for every millimeter of mercury increase in end-tidal CO2. When we looked at all of the succeedent shocks, neither of these were predictive. And in fact, the only thing that was predictive was a type of arrest that was a rearrest after a previous episode of VFib. So that was probably just a surrogate marker for EMS witnessed arrest in an immediate defibrillation. So what we really noticed here, and this kind of summarizes the results fairly nicely here in this graph, is that there's relatively poor prognosis there in terms of a successful defibrillation on the first shock when the end-tidal CO2 is less than 20. Only one patient with end-tidal CO2 of less than 20 was successfully defibrillated on the first shock. And when we went back and looked to see what was special about this patient, it turns out that this one patient actually was inadvertently hyperventilated at a rate of about 40 breaths per minute, drove the CO2 down to 5. So this was probably an outlier, not a valid indicator for this patient.
Just let me interrupt you because first of all, I know how it's possible to do 40 breaths per minute, unless you're going like this. So that's pretty funny. But yeah, so I think it's a good one to throw out. By the way,
clearly enthusiastic provider there. The striking thing we found was that there is a big difference there in the pattern that you can see here on the screen between those who had layperson CPR and those who did not. If we look here at those who received layperson CPR, there's a nice trend here of where we're doubling the rate of successful defibrillations on the first shock. With
so make sure I understand. Let me make sure I understand. So the proportion with ROSC is on the x-axis. You've got the end-tidal CO2 values grouped by 20, 20, 29, 30, 39. Okay, got it. Make sure we're all understanding that. And then the bystander CPR is in the dark black.
Yes, that is correct. And what we noticed here was there that without bystander CPR, once we got past roughly 20 on the end-tidal CO2, it was pretty much flat. So even if we had increasing levels of end-tidal CO2, the probability of a successful first shock remained pretty steady. So it just kind of underscores the importance of the bystander CPR.
Yeah.
In addition to the fact that we did find a correlation here between end-tidal CO2 and the probability of a successful shock.
And that's interesting because Mike Sayers on the phone, that probably is a great reason why they've always had such great successes, because they've had so many people. I think by the time I left there in 1982, about half the time when I arrived on the street, there were bystanders, plural, usually doing CPR. And it really does make a difference. This is really nice to show this that you got here. But I think it still is important that the end-tidal CO2 or with the bystander CPR is a terrific. Those are two great markers. But go ahead.
So just to kind of provide a little bit of detail here on the results there, our area under the curve was kind of moderate at about 0.64. And when we used the concordance probability method to look at the optimal threshold for the first shock, we found that it was 27 with bystander CPR and 32 without. So, Dr. Pepe, I don't know how much more results you want, or if you just kind of want to open it up to questions.
I think the general idea here is that, so if I was just to conclude things, there were two things that help you with predictability of the, so it begs the question, should we wait to improve the end-tidal CO2 before we shock? What if you don't? Does that mean you don't shock? You know, and there's all those kinds of questions. The other thing is the end-tidal CO2 clearly is obviously in this situation a marker for blood flow, right? Because blood flow returning back to the lungs to be measured. And so there are a lot of things that affect that. And I think it's a great tool otherwise, you know, for seeing are people doing ventilation right? And I'm not just talking about rate, but, you know, are they doing it correctly? Good good CPR, et cetera? Or are they using adjuncts such as ACD, ITD that will improve that flow better, or even up to the head up things and all that? So I think that we've seen it because, for example, when we started the latest cases we've reporting on the head up CPR approach, even with asystole patients, we're getting people with end titles in the 40s or 50s, and it clearly correlates with their good outcomes, et cetera. So I think this is really kind of cool work, and it goes along with the long-standing work people have done looking at median frequency, amplitude, et cetera. It really says the quality of the as you say, returning the ATP to those pumps are important. So anybody have any questions? Ginny, do you have anything else you want to comment about this yourself?
Answering methods questions in the chat.
Oh yeah, what were they asking? Just so you tell us what they were asking and give us your response.
Dr. Sayer was asking how pre-shock end tidal CO2 was defined. And so ETCO2 values were for the last breath preceding each defib. And they were measured as a continuous variable in millimeters of mercury. And then I was trying to get to how defibrillation was defined.
Yeah.
Not that that was a question, but it's an important distinction.
You want to talk a little bit about the epinephrine effect?
That's a Hubble question.
Okay, got it.
Yes, we did control for that in the statistical modeling, and the majority of the patients did receive epinephrine prior to the shocks, which is probably biased somewhat by the fact that only about 18% of the total shocks were first shocks, and the vast majority of them then were succeedant shocks. So it's kind of biased toward the succeedant shocks. I think it was about 93% received epinephrine, and then about half of them received bicarb, prior to those shocks. So
Right.
those were controlled for in the logistic model.
So there is literature that giving epinephrine before the second shock decreases ROSC survival and 30-day neurologic survival, and obviously similar data on bicarb. Could you talk about giving epi before the second shock and how that might influence your results?
And by the way, before you do that, before you answer that question, because people are going to have to start getting off, I just want to make sure they know about this study and where it's published. And it's published in, I think you can see this, I can never figure out how to do this right, in PEC, okay? And so if you can put a reference in the chart, but for those of you who just want to hear this, it was published in 2021 in Pre-Hospital Emergency Care, volume 25 and page 697, if that helps, all right? Otherwise, that helps you. You can get started, you can look through this because there's a lot of information in here. And that's why for the purposes of the call, I want to make sure I got to go through all this pretty well, okay? So,
Dr.
ahead.
Dr. Slovis, that was your question, right?
Which one, Bob? Which one? Corey, you want to re-ask it again?
I was just asking about epi before the second shock and why that was done, or could withholding epi till after the second shock have even improved more the likelihood of survival neurologically intact based on the available existing literature? And others, please jump in.
And it's an important point because both bicarb and epi can actually affect, in a sense, an artifact effect sometimes on anti-CO2 levels, right?
Yeah, the study was out of Get With the Guidelines about giving epi before the second shock.
Yeah. Okay, but go ahead, Jen, Dr.
So the way we defined shocks in this study matters. So the first shock was defined as the first shock that the patient received once EMS arrived without prior AED shocks. And then everything was coded beyond that as succeedant shocks. So it's everything beyond the first shock, which may or may not include whether or not the patient received a defibrillation via an AED. And then once they received epi or bicarb, they were then further stratified as succeedant shocks that received epi and bicarb. And so it's kind of difficult for us to tell between first and second. It's more like between first and any other. And again, this is retrospective data for us. So, you know, it's not structured in a way that we could have withheld epi and of course measure the outcomes related to that.
Yeah.
But certainly something interesting and worth exploring.
Yeah, so there's so many confounding variables and various things that affect other things that, you know, or timing, et cetera, that you couldn't tease out. But I think it's still hypothesis generating, and it's kind of a cool concept to be looking at the end title relative to that. And it does pose that question, you know, how long do you hold off the shocking if the end titles aren't looking good, right? Especially if they're under 20, which is a sort of a standard look for most people doing basic CPR, you know, at that time. So anybody want to make any comments about this or further questions for the group here?
So end tidal CO2 is measured with a device on bag valve mask because these patients are not all intubated, correct?
In our particular study, all of the patients had an advanced airway. About 3/4 of them were a biad of one flavor or another, and about 15% of them were endotracheal tubes. We didn't know this at the time, but it kind of played into our favor. There was a study published here about 3 months ago out of Toronto, where they were actually using BVMs to get their correlations between end tidal CO2 and defibrillation success. And they did not find a good correlation there with just using the bag valve mask. So it looks like even though it would be great to use a bag valve mask, we could get many more patients a reading and then make the decision about the defibrillation. But unfortunately, it looks like they're going to have an advanced airway before we can get reliable end tidal CO2 numbers.
So that would flip a lot of our protocols upside down because we have moved towards, you know, compression shock. Don't worry about the airway. Now we have to get a airway, get a good end tidal CO2 to know how to manage next.
So there's a question in the chat. Was defib delayed until the airway was placed? And no, you know, first of all, this is retrospective data. And so I'm sure some could have and some could not have it. It would just depend on the specific circumstances for each call. I think the important takeaway from this study is that a lot of the previous literature looks at this from a time-based angle towards survivability. And what we're trying to do here using ETCO2 as a biomarker is to really individuate how we can utilize defibrillation at the right time for each patient to maximize their survivability, or at least their return to spontaneous circulation.
Exactly. All right. Well, this has been really good. And again, it's you know, there's just a lot of questions and again, you know, all the issues like the retrospective, and you were controlling for everything, and clearly we're not controlling for the 7 factors that affect ventilation. I can go on, or the quality of the CPR. But I think that the bystander CPR signal is not new, but good. And it's really cool that you've actually tied it here to the end tidal too. Just an interesting association to see that coming through, because not the quality of the bystander CPR is not always good, but the more people you have doing it, the better off you are getting it. Let me go back to Michael Sayre in Seattle. Michael, how one of the problems I think with people who use with bystander CPR as a binary, yes or no, is the timing of that bystander CPR. I mean, I could make a run out to Magnolia Bluff, and these 2 guys were doing great CPR, and, you know, and we get them back, you know, because they were doing great CPR. But we could do a minute run down, you know, whatever it was, Empire Way at the time, MLK, and her bystander CPR was going on. But it turns out the person went down, they called the nurse across the street or the security guard down the hall, and then they didn't get it done for 5 or 6 minutes. And I think that was, our outcomes were pretty poor there. So do you do anything like timing of the bystander CPR relative to the collapse? Have you ever studied that more intensely, or anybody there done that?
I'm thinking about that. We are trying to measure
Actual
the,
arrest time as opposed to 911 call, right?
well, I mean, we have to use 911 call as a proxy for the arrest time because you don't really know. So we are measuring the time to starting chest compressions, and finding that I'm sure many others on the call have experienced this too, that many cases it's pretty straightforward, but some it's pretty difficult to tell when chest compressions actually started. And so we have not looked at that related to survival. We just don't have the power in our one system to kind of look at that.
Well, what's the percentage of people, when you lock it into the binary, yes or no, bystander CPR, what's the kind of percentage you're looking at on your calls now?
Oh, still about 55 to 60% who present in a shockable rhythm.
Yes. One of the reasons why I'm bringing this up is that it's again, one of my curses is I have this multi-dimensional thinking. And that one of the reasons I bring it up is that, let's say you have a community where most of the people are trained, such as you have there and elsewhere on the call. And that what happens is you're more apt to have someone start the CPR right away and not have to get the nursing, the nurse across the street or the security guard down the hall. If you have a lower frequency of people trained in CPR in a particular city, and that can affect the factor I just talked to you about, that the earlier you start it, the better off it works, that kind of, because after that, you have peripheral vascular collapse, and I could go on and on, et cetera. So just an interesting opportunity to talk about bystander CPR, especially with you on the phone. But anyway, so
and I think that there is, intuitively it makes sense. The earlier you get bystander CPR going, the better off your patient is going to be. So I don't have any reason to doubt that that's true. And I think our 911 systems need to do a better job with coaching people and getting bystander CPR going. I know many of us have an interest in that and are working on trying to make that happen, but it's hard.
Yeah, in the laboratory, they've shown it really well, like people like Gaz Murray and others. So it's great. Well, anyways, this is just the good stuff. And then the main thing is that really paying attention to end-tidal SU for a lot of reasons, not just flow, but what are your overzealously ventilating at 40 per minute, right? That was kind of interesting again. So that was it. Thank you guys very much. Anybody else have any questions or comments about this? I thought it would just help raise a few questions and things that we should pay attention to. All right. And
I think to the point that Corey made about I'm not sure what we should do with this info, and that it is interesting for sure that if that is replicated in other systems. I know locally we've continued to do 2 minutes of high performance CPR before shock. So I suspect in our data set we might not see this difference.
Yes.
Because it's already washed out by the EMS CPR that happens. If we were to look.
Yeah, I get it totally. So, and we're looking at the same thing, especially with priming the pump with other adjuncts and tools as well. All right, so I do want to get one of the things I wanted to talk about was Josh Hartman. I had him on the schedule last week, but I didn't see him to talk about the people who were proposing to make presentations to EMS world, and I think that's all closed out right now. Josh, but are you there still and want to talk about that?
Yeah, thanks. Thanks, Paul. So we were blessed with a record number of submissions again this year. We were at 545 last year and 688 this year. So great news is we have people interested in presenting at Expo. Challenging news is that we have to unfortunately then reject a record number, which we don't like to do, but it is what it is. I am wondering, though, if I could appeal to any of you guys to help us. We have a review process. We have a standard committee of 35, 40 people that review them. But because of the number, that we have, I could use some additional reviewers. Every presentation is reviewed by 3 people at least, and there's basically a category. It's a standard setup as to how it's reviewed. So if any of you are willing to review some presentations for Expo, I would greatly appreciate it. This is just a wealth of knowledge that you guys have, because right now with the number of reviewers I have, it would be at 50 each, and that's just too many. No one's going to be able to pay attention to review 50 presentations. So I think most of you have my email address, but I'll put it in the chat. The dates are September 18th to 22nd in New Orleans. So hopefully you guys, most of you, hopefully can be there. But if you are willing to help, again, I'll put my email in the chat. Just shoot me a quick email and I will get you added to the rotation of reviewers.
Okay, fantastic. And
Thanks, Paul.
so, oh no, thank you. And hey, are you available to talk just to do some follow-up tomorrow by any chance? I don't know.
Sure. Yeah, just text me or I'll text you and we'll find a time tomorrow.
Would around now be okay? Not now, I mean tomorrow, this time tomorrow.
Should be yeah, should be okay until 1 o'clock. So maybe like 12:30.
We'll do it earlier, 11:30, 12. Okay, good.
Perfect.
All right. So thank you so much. I just want to catch up on a couple small things. Won't take too long.
Thank you.
All right, so let's try to see if we can go around the horn. I think I've caught most of the topics that I wanted to do today. Hey, Libby, I just wanted to warn you, you may not be aware, but I think you need to have fair warning that Dr. Peter Antebi's in your jurisdiction. He is over there making trouble in Wailea, and I just hope you can keep a lid on it with him there, okay? Just so you know.
That's okay, as long as they keep him on the other island.
Okay,
Don't let
good.
him fly over here.
So tell me, you were talking about the air quality. I gave a talk last week from Libby Char. I was representing you and talking about the micrometer particles, and talking about but it would be kind of cool for everybody on the phone to hear a little bit more about Pele's hair, right?
So we had a recent volcanic eruption. Actually, 2 of them were going off at the same time. But one of the characteristics of the lava in Hawaii is when it's going, it sends these tiny little, I guess they're more like glass than anything, little glass fibers.
Yeah, fibers, yeah.
Yeah, so they call it Pele's hair. Madame Pele is the goddess of volcanoes and fire. And so they call it Pele's hair. And it's just these really thin strands. So we just warn people to, wear masks and whatnot, especially those that have respiratory illness. Some of it is the sulfur dioxide and some of it is particulate matter. So obviously N95s don't do anything against the gases, but it will protect against ash and Pele's hair and little particulate matter in the air. So we measure 2 things in the Department of Health. We measure the particulates less than 2.5 microns, and then we also measure the gases, particularly SO2. So thankfully the volcanoes seem like they've both died down in the past 24 hours, no longer threatening the roads. So that's a good thing for us.
So the one good thing about the SO2 is that if you're getting near it, you can kind of start to smell it, right?
Yeah.
Right. Yeah. So that's okay. Go the other direction, right? Which is great. Anything else new to report from Hawaii? Everything okay there?
No, it's like everybody else. The hospitals are full, but it's not with COVID patients or respiratory patients. They're just full, and so it's staffing shortages are also contributing.
And since you're Oconus, any issues with drug shortages, that kind of thing, or any of that yet?
Yeah, the usual ones that, thankful to Jim for sending out the updates, but yeah, it's the usual ones that everybody else is dealing with.
Okay, good. Well, let's go from one extreme to the other and go over to ASADA. What's happening in New York? You're usually the canary in the coal mine for anything, right?
Yeah, our volume's still, 500 a day more than usual, so about 4,700.
Are they mostly sick calls, or are you adding in the violence with shootings with the teenager?
Yeah, it's a whole host of everything, but I think, now with influenza actually going up and COVID again going up as well, our PEDS folks feel that we've plateaued on RSV at the end of last month or about now. So hopefully that continues, but we're just the call volume, with the violence, as you said, the gunshot wounds, the 17-year-old killed the other day. It's just crazy. So we keep monitoring and we'll see what happens.
Okay, got it. Well, thanks a lot. It's always great to see you then, and appreciate that. And I guess I'll run down 95. Is Crawford still here? maybe not. Yeah, I don't see him anymore.
And, you know, I'm sorry, just on with Crawford, I know in Philly, he's having a xylazine problem and he sent that out for us. It's great. Yeah, I've been checking with our OCME and I just checked again, last was August and just recently, we have not had increased cases, luckily, from the OCME. I think it's almost like carfentanil for us. We didn't actually get hit as bad either. I don't know why we're being missed, which I'm very glad that we are.
Okay, hey Crawford, I see you're on. It looks like you're on there, but I don't know if you
Yeah,
can.
sorry, I had to jump off for another meeting for a bit.
Oh yeah, well, I just want to see anything going on in Philadelphia outside of xylazine, right?
Our number of fire deaths is sort of ticking up a little bit compared to the last couple of years, which is we had 2 fire deaths over the weekend, which is just
Are you
kind of
talking
sad.
about you're talking about citizens or line of duty thing?
No, I'm sorry, citizens.
Okay.
Yeah, and no clear reason. And I think that's pretty much it. I mean, we've got all the same normal stories of woe that everyone else has got.
All right, got it. All right, great. Always love having you on, man. You're always great. You're, I would say you're the most understated hero here. Just you're so good at what you do.
Hardly.
So thanks again. Yeah, hardly right. You do it. Let's go down 95 a bit more. Ben Launer, what's happening in Baltimore? Ben, are you there still?
Hey, everybody. How's it going?
Yeah.
For asking. So Baltimore continues with the challenges, much like everybody else. We unfortunately, our chief was resigned in the wake of a report came out about the line of duty fire deaths. So we are in a very big state of transition with a bunch of assistant chiefs that are kind of doing a rotating leadership type thing. So lots of meetings with the city, trying to not lose progress on the expansion of the EMS division, a lot of our population health projects. So I think we are certainly a reflection of all the other urban challenges that are going on, but otherwise status quo.
Okay. Well, I'm going to run down the 95 further and then cross over to the Tampa Bay area and take advantage of Angus. Angus, anything to report either from the state of Florida, where you're the state medical director, or Tampa Bay area? Angus, are you there? Maybe not. Yeah, Angus is on a lot of different calls, and this may be him piping. He may be on here to pipe in the Florida people, but I think he had something major that was going on, so we'll have to skip him. Let's. I'm just going down a little bit alphabetical now. David Miramontes, anything to report out of San Antonio?
Yeah, so a couple things. So first of all, the flu and all that kind of stuff is being a problem here, and we're really having a problem with offload times for the first time. So that usually isn't an issue here. We've had some big wall times, and I'm getting cranky. So I actually reported my first hospital for an EMTALA violation for keeping my guys on the. I'd had enough. So that's going to be kind of the test case to see what they're going to do about that. It was an egregious case. The patient died. So we'll see what happens. And I'm sure that's going to send a little shockwave.
And Dave, the issue about the EMTALA, I want to reinforce, is not just that you cross the hospital grounds and they have to take you, or they're not taking people fast enough, or, technically, as we know, they oversee hospitals, not us, and we can actually just leave them there. We ethically don't do that. But the other thing that when we had him on the call last year, the guy who runs this thing for CMS, it was that interesting point was that the paramedics are not credentialed to work in the hospital. Even if they work as a part-time job, they're not on duty for that at that time. And so part of it is to also bring up the fact that to our people at the public service side, not only the thing where you could sue them for theft of city services, but the issue that you can't put them at risk with CMS by practicing medical care, which includes monitoring, by the way, in the hospital. So that's just another thing to bring up as this boils over with you, okay?
Yeah, this case was a failure to do a timely medical screening evaluation and timely stabilizing treatment. They didn't do that. And so there was a bad outcome. And actually, it's kind of weird. We were giving whole blood on the wall in the waiting room So it was an egregious case, but this has been coming up repeatedly as a problem. So interestingly enough, Texas is Texas. We can't mandate mask use, but in the hospitals they can. And if you write an EMS protocol that says that your members, as part of your medical care, you can mandate masks. So
But you can't do it in the stations or anything like that, or on the,
correct.
or on
Only
the, or in
home.
the ambulances respond, right? Can
Right.
you put in the protocol out as you're responding, wear them or something? I don't know, whatever.
Wish. But
Yeah.
unfortunately for us, it's again, it's the flu and the RSV that's really the big issue. And the people that we have with COVID aren't as sick as they were 2 years ago for whatever reason.
Yeah.
Probably it's the partial immunity process. Of course, that has been the driver here, but we're not seeing the absenteeism in the firehouse like we did over the last couple of years. So even though it's ugly, our workers are still coming to work, thank God.
Yeah, okay. David, other than the classic thing where your people were threatening to sue for theft of city services, any other advice that you'd have for David, or thoughts or comments to make?
Yeah, if you're talking to me, Paul, no, I don't, we,
Yeah, I am talking to you. Sorry. Yes.
yeah, no, I got no magic sauce there.
Okay, got it. Hey, then speaking of David's, then let me just jump over to David Obert in Vancouver. So what's anything new to report from Canada? David, are you there?
Yeah, I'm sorry.
Yeah.
Yeah, not much beyond what's been reported. I mean, I think obviously we also, from a respiratory illness and specifically for PEDS population, there is a lot going around. It is significantly backing up our children's hospitals. That then does have ramifications for the EMS service, because BCEHS is involved in interfacility transports, and they are few sort of admitting pediatric facilities in the Lower Mainland here. It's not so much COVID, it's primarily flu and RSV. I think our flu test positivity was 24% for flu A, and RSV was about 8%, but the COVID cases have been, I think, relatively stable.
I'm going to ask John Jew and Eileen next week to actually, if I can remember this, to do that, or someone could ask me to remind me to ask them. Is that our COVID tests like less sensitive now because they were originally created for the alpha virus? Is it just still the spike? Does it change anything? Is the identification of this, the spike by the test changed at all, or is there a possibility that that we got people with COVID, but we just don't know it because of maybe the sensitivity of the test? I think it's an interesting point to bring up now, because I don't know what tests we're using, and it may be variable depending on what test you're using as well. If they're old ones or new ones or whatever it may be. Just an interesting, question to bring up that we'll do. Okay, I'm going to put that down, sensitivity of COVID tests, because my gut is telling me that it may be that the testing that's there, not that the COVID. And as David's saying, in Houston, the water levels are going up, that kind of, the sewage levels are going up. All right, let's shift down to Jeff Jarvis. What's happening in Fort Worth now that you're a veteran there, right? It's been what, over 3 or 4 weeks now or something like that, Jeff, right?
Well, there we go. It's
Yeah,
amazing. Sometimes you got to click buttons. Yeah, I think veteran is probably a gross exaggeration. I have figured out where the bathrooms are. We're still working on setting our priorities, most of which is going to be really overhauling essentially dashboards, like I heard earlier, trying to get our metrics up in shape. And then we're also continuing the work that Veer started here on reprioritization.
Yes.
And we're also taking a look at what the impact of squads essentially is, as David was calling them, up here.
Yeah, it's been working out pretty good for everybody initially already. I'll talk to Lakshmi about it, but Jeff Goodlow's having fantastic success with it, and we know David's had it for years there, that kind of thing, and really a well-honed system. And then I think we, of course, originally got the idea from Seattle, because we had 1 or 2 units, and the rest were just 8 cars backing us up, and then we had to spread out a little bit more. But it makes sense, since 90% of the calls we get don't really need a paramedic per se. I mean, you could argue a few more might need monitoring for advanced life support, but not that many nowadays. So especially in a big city. So that's where this is a more apple is the big city. So all right.
Yeah, and my objective is to narrow down the number of people so we can deal with the skill dilution issue.
Yeah. That's so important. So thank you.
Yeah,
Let me, I'm going to skip over John real quick, John Kramer, but I will come back to you, John. Although it's getting pretty late. Lakshmi, maybe I should have you come on next time and talk, but are you okay if we switch to 3:30 your time in the new year?
Yeah, it works for me.
Good. Okay, good. Well, anything new to report from your end, especially on the end of operations and so on? Anything new happening there in staffing?
No, we're actually doing really good on staffing. I think our biggest issue now is wall times. Like David was saying, just because of the hospital shutdown, our wall times are going off the roof. With
I mean,
what
didn't Atlanta Medical Center shut down or something like that? Is that
Yeah,
right? Oh, wow.
unfortunately. So
Yeah.
that's the second hospital within the city of Atlanta to shut down in the past 2-3 months. So everybody's really feeling it. Interestingly, our flu numbers are gradually going down in the ER, and our COVID numbers are creeping up a little bit, which I was like, oh, let's not go back there again. But other than that, we're doing okay.
All right, good. And great to see you. Rob Lowe, we haven't seen you for a couple of weeks. So anything to report out of Columbus?
Actually, our weirdest, newest thing is we're dealing with a measles outbreak in the community right now. So apparently we have the largest measles outbreak in the United States right now.
Tell me about that then. What's the rationale for it? Is it people just having vaccine, whatever, with their kids, or is it adults or children that have the measles?
It's mostly children. So as of yesterday morning, I think it was 73 cases, 68 of them age 5 or less. Not a single one of the cases is fully vaccinated. I think 4 of them had a single dose. And part of the reason it popped on our radar is because there is a bit of a hot spot in one area of the community. So making our providers aware and,
I mean,
and all
it's
that.
so contagious. So that's gonna hope adults don't get it because they get real sick, you know.
Well, and interestingly enough, our hospital admission rate's a little higher. So historically, everyone was quoting to us, 20%, 1 in 5. It's about 34%. And I don't know if that's, the illness of the children involved, the age of the children involved, or just the fact that we haven't seen it in a long time. And so folks are a little bit more uncomfortable, but it is higher than expected.
Yeah. And it's pretty typical presentations, by the way. You're not seeing anything different in presentations, right?
It seems like it in talking to our children's counterparts. They don't seem fooled by the cases.
All right, got it. Stein, anything to report from your end?
Nothing new from different than what everybody else is reporting. Our children's hospitals are full. The adult hospitals are taking the overflow. We don't have the wall time issues that others are reporting, but all the same.
Okay, good. And John Kramer, any wisdom you can shed upon us here? John, are you still there? I don't know if you got off or not. May have lost him. Okay, or gone off to something else, which I don't blame him for. So anyways, John Kramer, I'll give you one last shout. Okay, and so anybody else want to pipe in with anything and or make comments or suggest that we do next week, besides some of the infectious disease questions I had myself? All right. Well, with that, welcome back, my friends, to the show that never ends next week. So that will be December 20th, and then I'll try to still run one on December 27th. And then after that, be advised, like I think it's whatever it is, January 3rd, I will try to move into this 3:30 Eastern, which would be 12:30 Pacific, etc. And then I think, does that throw you just back an hour? That's like 11:30 in the morning for you, I think, Olivia. I hope that works for you. So. All right. Well, with that, I'll see everybody next week. Thanks again. And welcome back, my friends, to the show that never ends. Appreciate it. Thanks for everything you do on a day-to-day basis. Take care. Bye-bye.
Thanks. Bye.
Thanks, everybody.
Paul.